Hello and welcome to this Practicing Clinicians Exchange podcast. I'm your host, Nicole Mitchell. This is the second of a three-part podcast series based on the webinar, The Biggest Risk to Cardiovascular Health, Addressing Social Determinants of Health in NVAF. Today's episode features Laura Ross, Physician Assistant in Cardiology at the Park Nicollet Heart and Vascular Center in Methodist Hospital near Minneapolis, Minnesota, and President-elect of the Academy of PAs in Cardiology. Laura discusses strategies to address social determinants of health that impact NVAF. For more information on Ms. Ross and all our faculty, along with the CE/CME certified on-demand webcast with downloadable slide set and a clinical thought commentary, please visit pce.is/NVAF. Now, let's get started and hear what Ms. Ross has to say regarding strategies to address social determinants of health in NVAF to improve clinical outcomes.
Those of us in healthcare take care of about 20% of what this impacts, the access to care and quality of care. I feel like we have a better handle on that. However, there's 80% of the rest of the factors, including physical environment, social determinants, and behavioral factors, drive outcomes as well, whether that's health behaviors, diet, exercise, physical environment, and then finances, education. We're going to dive deeper into what those are. And many studies confirm that if patients have lower income, that leads to higher rates of cardiovascular risk factors, adverse cardiac events, and more deaths in patients with atrial fibrillation. Conversely, patients who have higher incomes and wealth have improved healthcare access, provider decision-making, and clinical outcomes. And so let's look at that a little bit more. So the first social determinant of health that most of us are aware of is financial resources. And certainly, if there's a worse socioeconomic position, there's a higher incidence of atrial fibrillation. AFib is higher among patients that are unemployed versus employed. The ERIC study that Dr. Kountz reviewed showed that the AFib incidence was higher among lower income households versus higher income household participants. And what if those patients try to work longer hours? And to make up for that, unfortunately, working longer hours was shown to have a 1.4-fold increased risk of AFib versus standard working hour individuals. So why is there a difference? And part of this is we can see a difference in oral anticoagulation prescriptions. It's underprescribed globally for preventions of stroke and AFib. And part of this is financial status, certainly. Part of it is patient-level clinical factors. Do they want to take the medication? Are there comorbidities that inhibit that? There's also provider-level knowledge or comfort influence. What's their prescribing pattern for anticoagulants? Do they come from a country that has low income, that might not have the same resources? And insurance certainly plays a part as well. But what I found fascinating was this Canadian study that showed when can we see a difference. So initially, neighborhoods that had high incomes had a higher rates of DOAC versus warfarin prescription. Interestingly, the addition of DOACs to Canadian drug formularies in 2012 led to a disappearance of income-related prescribing disparities. So a sign that we can make changes here if bigger changes take place at the insurance level. In Sweden, a similar story where higher socioeconomic status increased the likelihood of DOACs versus warfarin prescription in those in the highest income compared to the lowest income. This came out in the Journal of American College of Cardiology just a few months ago and really looks at the equity-centered quality improvement model. How do we shift the status quo? And I agree, it often has to start with insurance. They need to start, or hopefully will start, payment incentives that reward equity. And this is going to motivate delivery systems to change their structure to address these social drivers and disparities of care, really encourage them to diversify their leadership and workforce. We know that patients do better when they see people that look like them and can make these important decisions. If insurance companies can provide equitable benefits, this is going to help communities invest in their healthcare, which can counter structural racism and help reduce segregation. And this all comes down to the patient's risk factors. If we can help improve access to get into this delivery system that is changing, that is rewarding equity, then we're going to see reduced cardiovascular outcome disparities. And this is going to improve the patient experience. If patients start to increase their trust because they see that these equities are being met, we are also going to have better outcomes and more follow-up. So There's a lot of financial resources that come with atrial fibrillation with the treatment before and after, and probably the most debilitating symptom we would agree on is stroke. It's more common, unfortunately, in individuals with AFib and low income. We have seen time and time again in these studies that patients in the lowest income have an increased risk of hospitalization for stroke and fatal hemorrhage, in particular, if patients are over 65. On the flip side, patients with higher socioeconomic status have a lower all-cause mortality versus those in the lower socioeconomic status. And in the United States, you'll see here that similar findings, those in the lowest quartile socioeconomic status have significantly higher mortality versus those in the highest quartile. Now, in an insurance claim database, assuming that means they have insurance, patients with AFib in the United States didn't show an association of risk of stroke and income level. However, there was an inverse association between the income level and rates of hospitalization. So income's up, rates of hospitalization are down, income is down, hospitalization goes up. In particular, studies have also shown a higher risk of hospital admissions for heart failure with atrial fibrillation. The next factor I will dive a little deeper into is rurality. And as Dr. Kountz mentioned, this is a factor that contributes to poorer health outcomes in atrial fibrillation. There's decreased access to healthcare services, and in particular, healthcare clinicians. That's where PAs and nurse practitioners, as well as our physician colleagues, really want to get a guideline-based care out to these rural communities. We know they suffer from lower income to afford care and have lower education levels. In a 2012-2014 US inpatient registry, over 60 million individuals, about 20% of everyone in that study, resided in rural neighborhoods. This is a big problem, and patients with AFib admitted to rural hospitals had a higher risk of death versus those who are in urban hospitals. Now, I round in a rural hospital and clinic and then also go into the city, they call it, to round there. And I hate to hear this, that there is such a difference in care for the exact same problem. In Canada, they also found a higher likelihood of inappropriate dosing of DOACs for AFib for those in rural primary care practices versus urban primary care clinics. And in Sweden, patients with AFib were half as likely to be initiated on a DOAC versus in an urban area. So what can we do? This is so depressing, right? The good news is we do have some tools. So one chief point is to decrease the variability in approaches for evaluation and also rollout. So in Minnesota, where I'm from, we have a little clinic called Mayo Clinic. You may have heard of it, that has really taken over some of the rural areas and standardizing care and getting their doctors to do outreach in those sites. And I'm hopeful that other organizations have done similar things or will, if not already. We really need to promote guideline-based care. So all the national societies, the American College of Cardiology has apps now that they've developed that even if you're a rural doctor up in Antarctica, you can get clinical decision tools to help provide guideline-based care. Could university or teaching hospitals help decrease those research gaps? So Minnesota, where I'm the most familiar with, they have a rural track program for primary care physicians up in northern Minnesota. And they found that those graduates, 41% of them, plant roots in rural community to practice versus graduates from other medical schools where only about almost 14% practice in rural areas. The urban life is alluring for many reasons, but can we change the training, and maybe throw in some of the education about social determinants of health in that as well? Can we support education to youth, job training and mentoring, summer employment for these rural youth who have roots planted in the rural communities to learn more about healthcare and what options are? And then consider use of clinician decision support tools. Although some studies show there isn't an effect, all that means to me is there's opportunities to develop these. It makes sense that if we have the tools, we can standardize care and improve outcomes. And telehealth, haven't we learned so much in this pandemic about how telehealth is so important and easy to deliver care to someone who lives hours away and standardize guideline-based care? And even initiate remote INR monitoring for those patients on atrial fibrillation and help make sure they're in the therapeutic range. There's also neighborhood factors that can make studying atrial fibrillation challenging. We know if there's socioeconomic deprivation in neighborhoods, that leads to poor access to healthcare, healthy food, safe green spaces to exercise, leads to poor health. And this results in differences in atrial fibrillation incidence, management, and outcomes. Individuals in AFib who have high socioeconomic status backgrounds are more likely prescribed oral anticoagulation. And then we also know, conversely, that patients in low socioeconomic status areas have increased risk of death. It's not just neighborhoods and finances, there's also environmental pollution. So in the United States, individuals residing in counties with low income levels have a higher proportion of underrepresented racial and ethnic groups. Many studies have shown this. And when you live in those areas, there's higher levels of environmental pollutants. This leads to lower life expectancy versus countries that have higher income levels. And when they boil this down, they see there is an association between air pollution and atrial fibrillation. In fact, looking over 5 million residents in Canada, those who were exposed to high levels of pollution had an increased risk of new onset AFib. They also found an increased risk of ischemic stroke for those in the United States who lived in a high industrial activity area. Interestingly, it's not just environmental pollutants, but road traffic noise. This was a new thing for me to learn, that even led to 6% higher risk of incident atrial fibrillation for every 10 decibels of increase in road traffic noise. And so even though these little percentages are small, when you look at the vast amount of people in urban areas in particular that are exposed to this, it really does add up. One of the last things I'll touch base about is health literacy. So health literacy is the capacity to obtain, process, and understand basic health information and services really needed to make appropriate health decisions. And this is prevalent worldwide and really affects health outcomes, utilization, and cost. This is a little different than limited English proficiency, and it's where those patients have a primary language other than English. Now, 36% of the United States adult population have limited health literacy, really understanding what we're saying. 8% have limited English proficiency. And when they've looked at ethnically and linguistically diverse sample patients in the United States taking warfarin, 40% of those patients had an inaccurate perception of stroke, and 33% were able to describe the signs of a stroke. This is an important topic that really isn't addressed in the guidelines yet. So we're going to get back to that 56-year-old Black female with uncontrolled hypertension, type 2 diabetes, BMI of 38, was noted to have palpitations and weakness on a recent exam. Her EKG showed atrial fibrillation, and she was started on warfarin, but had wide variations in her INR. She was given a prescription for rivaroxaban, but it wasn't covered by insurance, and it was never filled. What factors may have led to her wide INR variations? We'll move on to some of the factors that may, is this health literacy, language proficiency, and AFib treatment. We know this is important because AFib is a condition that requires self-management and symptom recognition and adherence to medications. We know if there's not high health literacy, there's less time in therapeutic ranges, and social determinants of health intersect with language proficiency through multiple pathways. I think at the center is shared decision-making. If at the end of the appointment, we feel like a patient should be on a blood thinner and we give them the prescription, we don't understand the obstacles that are in the way, that is not patient-centered decision-making. And we're not the only ones who think this. When they did an international survey of physicians, 46% of the respondents considered their patients unable to explain atrial fibrillation adequately. We certainly need more studies on this and to learn more about how do we combat this and take this into account. So what can we do? What are some interventions to improve our patient-provider interactions? One certainly is to improve our linguistic and cultural competencies. I think signing up for this PCE webinar is a great first step as well. Just becoming more aware of what are the issues is the first key. Using interpreter services. In the times of COVID and a pandemic, it became very clear that it was easy. Push of a button, we had an interpreter at our fingertips helping patients understand what was happening. It's important to have racially or linguistically concordant healthcare providers and staff. And I learned this when I reached out to an inner-city PA school and asked for students to come work with me. Patients I had known for years, when they saw a student come in who looked like them or spoke their language, their whole body language changed. And the connection I saw was pretty powerful and keeps me motivated to continue to have students with diverse backgrounds, to let those students shadow me if they're interested in healthcare and how it works both ways for patients and also those incoming students. The other thing I really like to use is Google Translate. So I will type out my after visit summary on a Word document, or we have an electronic medical record system. Put it into Google Translate, copy and paste it, and you can pick any language, Farsi, Mandarin, Cambodian, and it will translate it even into characters. Then I copy and paste that right back onto the paper. The translators will review it and make sure there's no glaring mistakes. And then the patient's able to take that home. That really limits the risk of missing something in that barrier of communication. I also utilize pharmacists and electronic medical records to check on prices prior to prescribing potentially cost-limiting medication. So if I have a patient with social determinants of health, the nurse that I work with knows that I'm going to be tapping her shoulder to call the pharmacy when I send the prescription. So if I put rivaroxaban, and our electronic medical record will have a big red X if either not covered or PA, it needs a prior auth. For some medications, it will say what tier it's on or how much the medication is. And if I get any of those reactions, I know how to act accordingly, and then have my nurse contact the pharmacy. How much is it going to be? And then they ask who's English speaking that I can talk to about this when I call back, or we'll use an interpreter and do a lot more hand-holding to make sure that we're all on the same page. Social support is one of the other social determinants of health. And we know that if you don't have social support, there's a higher incidence of risk factors for AFib, obesity, tobacco use, alcohol consumption. We need to look into this more. We know social connections have some protection. People that are married or partnered have less cardiovascular mortality versus those who are single. And there has to be beneficial to strong social integration is beneficial to health, even with other social determinants of health. And is there a role for protective factors in spirituality or social support and resilience? I'll briefly review. There's a digital divide in social connection. So if people that are underrepresented for racial and ethnic groups, low income, aren't as connected digitally, but for those who do have access, there's over 200 apps. However, the mean readability score is quite high at 12 plus or minus 2.6 grade levels, even though recommended is 5th to 6th grade. But there's a lot out there, and it's unknown whether this really helps improve social support, but it's worth looking into. And I would like to point out that there are free resources on Facebook or Twitter for atrial fibrillation. If you just type that in, you'll find that, as well as the stopafib.org is a great organization to read for patients too. So I will end on this slide, the 5 A's to address social needs of patients. Awareness, you have all taken that step in logging into this webinar and really learn to identify what these risks are. Adjustment, looking for language and literacy concordant services, offering off-hour times when people might be working different hours and shift work, reaching out in telehealth in rural areas, assistance, how can we help address social needs, involve social workers or nurse coordinators in your practice, alignment, look at the community to organize and rally around these patients and help improve outcomes. And lastly, advocacy. Go to the Capitol, Days on the Hill. Almost every organization has that to really advocate for policies that can help address these social determinants of health. And so with that, I thank you for having me and letting me talk about something I'm so passionate about.
Thank you very much, Laura, and thank you to the listeners for joining us. Please take a listen to our final episode with Dr. Keith Ferdinand, who will examine the effects of social determinants on health on anticoagulation prescribing in NVAF, and look at areas for future study to better understand and address these social determinants. As a reminder, to view the full program and to join the discussion, please visit pce.is/NVAF. As always, thank you for listening.